Good evening, everyone. First of all, I would like to congratulate our newly elected board, hoping the coming 2 years shall bring nothing less than more success and prosperity to our society and to our beloved Lebanon. I also would like to invite all attendees to register to and try to join us on our yearly annual meeting, which will be held in Beirut on September 30th and October the 1st, 2022, under the slogan of "Like a Phoenix," which symbolizes our eternal belief in the capacity and capability of our country and its people to rise again. This webinar, the first among a series which shall be presented every 6 weeks, is intended to focus on key lectures which were presented during the last European Society meeting in Milano. Our speakers are professionals in the capacity of experts in their field. Whoever feels like asking a question for the speaker, please let us know by raising their hands or posting their questions on chat or Q&A. Our first speaker is Professor George Abitaya, Associate Professor at St. Joseph University and Head of Obstetrics and Gynecology at Hôtel Dieu de France. He has a PhD in bioethics and will be speaking to us about what is new in endometriosis. Professor Abitaya, past president of the Lebanese Fertility Society, the screen is yours.
Thank you, Walid, for inviting me, and hope this first webinar will be one of a successful series, and hope for you and for all the board all the best of luck for the new 2 years of Lebanese Fertility Society. So I will talk tonight about endometriosis. My talk will talk about what happens this year in Milano for the ESHRE meeting 2022. The references will be ESHRE guidelines. This year we have the new ESHRE guidelines 2022 for endometriosis, and eight presentation in ESHRE in 2022 about endometriosis. So we'll begin with the ESHRE guidelines. The problem is with endometriosis, we have a significant delay for the diagnosis of endometriosis, and this will cause an enormous burden worldwide. There's a classification actually for endometriosis: superficial endometriosis, ovarian endometriosis, and deep endometriosis. When we talk about deep endometriosis, we talk about more than 5 millimeters endometriosis. How we can put a diagnosis for endometriosis? The new thing in the ESHRE guidelines 2022 that laparoscopic diagnosis for endometriosis isn't anymore the gold standard for the diagnosis of endometriosis. They were talking about many things to put the diagnosis of endometriosis. First of all, they talk about biomarkers. The first biomarker is PGP 9.5. It's a protein gene product. The sensitivity is 95%. And specificity is 95% also. So it's a very good tool to put the diagnosis, but the problem is that all the studies about this marker were with a considerable heterogeneity. So we don't have a recommendation, direct recommendation actually, to use it for the diagnosis of endometriosis, but it's a promising marker that can help us without any invasion to put the diagnosis of endometriosis. There is other neuronal markers, many of them. They show promise, but the evidence was either poor quality or insufficient. So we need more time to have really a biomarker to have the diagnosis of endometriosis. The old biomarker of endometriosis, CA125, has a sensitivity of 93%, but it's low sensitivity, 52%. In these cases, it's not recommended to put diagnosis of endometriosis only on with this marker. In the ESHRE, there was many presentation about biomarkers and endometriosis. 3 of them were about 3 biomarkers, different biomarkers. First of one, they were talking about CD44 with small extracellular vesicle, and they found that we have more CD44 in the peritoneal fluid in endometriosis. It was a team of the United Kingdom, and the same team proved that this same CD44, we found it in the blood samples, but the study based on a small sample. So if we found CD44 in the blood samples in patients, we have a high sensitivity and specificity to found endometriosis. And this is very important for superficial endometriosis that we cannot see with imaging, with ultrasound or MRI. The last presentation was about state 5 signalization. It was a blood test that shows that there is an ovarian endometriosis. So these 2 biomarkers was proven, but with the small samples, that they are specific and sensitive for endometriosis. For the diagnosis of endometriosis for the ESHRE guidelines, they prefer for pelvic superficial endometriosis to use laparoscopy. For ovarian endometriosis, transvaginal ultrasound with a specificity of 96% and sensitivity of 93%. And for the deep endometriosis, MRI with a specificity of 77% and sensitivity of 94%. So for pelvic endometriosis, superficial, less than 5 millimeters, the only gold standard for diagnosis is still laparoscopy. What we can give the patient for the pain in endometriosis. We can give contraceptive pills, progestogens, GnRH agonists, and GnRH antagonists. Contraceptive pills could be by oral, vaginal, ring, or transdermal. It has a good action for dyspareunia, dysmenorrhea, and non-menstrual pain. So ESHRE guidelines recommend the treatment for long-term with contraceptive progestogens and agonist or antagonist for painful people with endometriosis. Progestogens alone reduce endometriosis-associated pain. We can also use levonorgestrel releasing intrauterine system or etonorgestrel releasing subdermal implant. And it's recommended to reduce endometriosis-associated pain. For GnRH agonists, we don't know with this recommendation the real dosage and duration of the treatment, but they prefer to keep it as second-line treatment because of the side effect profile. And they prefer to give with GnRH agonists a combined hormonal add-back because of the risk of bone loss and all the signs of hypoestrogen. For patients with pain refractory, even with contraceptive pills or progestogen or even GnRH agonist or antagonists, they recommend to give aromatase inhibitors. They can give it alone or in association with contraceptive pills, progestogens, or agonists and antagonists. The endpoint will be surgery also when we have a rebel pain and we need to give a treatment more than aromatase. In surgery, they recommend to do excision instead of ablation to have less recurrence and more effect on pain. Initially, also, there was a presentation about botulinum toxin in pain in endometriosis. It was a team from the USA, and they demonstrate that if we give injection in the pelvic floor for endometriosis, and especially for chronic pain endometriosis, we have less than 50% after 1 year relief of pain. The problem is we have to repeat this injection every 6 months or every year, but there is no adverse effects. And the botulinum toxin injection was well tolerated by patient. So this one of the treatment also, a new treatment for the treatment of pelvic endometriosis, especially for deep endometriosis with a pelvic floor muscle spasm. Another presentation was about complementary therapy presented by a team from Austria. They show with their study there is an improvement of the pain only with exercise, supplementation with vitamin C, E, selenium, melatonin, and curcumin, some yoga, some homeopathy, less omega-6 because it's pro-inflammation, and more omega-3 with medical cannabis, acupuncture, and electrotherapy. So they do many subgroups, and they give one of all these items for this subgroup, and they have a significant difference in pain for all the patients with all this subgroup. So they recommend that we do an education for this patient and a supplementation to improve their pain for chronic pain in endometriosis. Now we'll talk about endometriosis associated with infertility. What they recommend that for women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rates. So after surgery, we don't have to give GnRH agonist or something else to improve the pregnancy rate. After surgery, normally, we have to leave the patient to get pregnant immediately. If the woman decides to not conceive after surgery, we can offer hormonotherapy to improve the outcome of the surgery and for the pain and to reduce the recurrence rate. So if we want to have a pregnancy after surgery, we shouldn't give any treatment. If the woman does the surgery for pain and she don't want to conceive, it's better to give her some hormone therapy to improve the outcome of the surgery. When we have to do surgery in endometriosis associating with infertility, we can do a laparoscopy when we are in the stage 1 and 2 of ESHRE. This will improve the rate of ongoing pregnancy. We shall be careful in this case to not have any other cause of infertility, male infertility, low ovarian reserve, or any other thing. So we do the surgery only when we have only the endometriosis as cause of infertility and in only the stage 1 and 2 of ESHRE classification. Never do a bilateral surgery to avoid a reduce in the low ovarian reserve. There is no evidence that surgery for deep endometriosis improves fertility. So when we have deep endometriosis, no need to do surgery before conceiving. And how we can identify the patient to treat or to not treat, to do surgery or to do ART, we can use the endometriosis fertility index that can give us an idea about the treatment of the patient. If it's very low, it's better to go to do ART, and it's a very high, we can do a surgery, and we have more than 50% of pregnancy rates after surgery in stage 1 and 2 of ESHRE classification. So this is an example of endometriosis fertility index. It's anatomical, so about the fallopian tube, the ovaries, and everything we can see. And even it's about the age, the years of infertile, the prior pregnancy, if she has or not, and all the scores of endometriosis. And if you have a low score, we have really a low rate of pregnancy rate without any ART. And if the score is high, we can use it to do only surgery and to keep the patient get pregnant alone. When we have to use ART in endometriosis, ART is indicated when we have associated with endometriosis any tubal function abnormalities or any male factor infertility. And if you have an index, very low index in the endometriosis fertility index. In this case, no need to do any surgery before ART, and you go directly to ART. For ART in endometriosis, I recommend to use antagonist or agonist protocols. There is no superiority of antagonist or agonist protocol in endometriosis, and we have the same pregnancy live birth rate. We should know also that for endometriosis, the ART is safe, and ART is not something that causes increase in the development of endometriosis. And we should know also that in women with endometriomas, clinicians should use antibiotics during oocyte retrieval. They recommend that extended administration of GnRH agonist prior to ART treatment is not recommended anymore and will not improve the pregnancy rate. So we don't have to give agonist for 3 or 6 months before ART, even in severe endometriosis, because it doesn't improve the pregnancy rate. And there is sufficient evidence to recommend prolonged administration of contraceptive oral pills of progestogen before ART. So no need for agonists and no need for hormones in endometriosis before any ART. When we have a low ovarian reserve, we should know that surgery for endometriosis is very bad for the ovaries, and we will find ourselves with a very low ovarian reserve. So when we have a big endometriomas with a low ovarian reserve, there's a big risk of menopause after surgery. So we have to avoid the surgery when we have a low ovarian reserve. Deep endometriosis, we should offer it only for pain and not for infertility. And when we have a extensive ovarian endometriosis, we should discuss with our patient for fertility preservation. Is no any plan to conceive immediately. So endometriosis now is an indication for fertility preservation to avoid any progression of the disease and any problem of infertility in the future. We should know also that pregnancy will not improve the prognosis of endometriosis, and pregnancy does not always lead to improvement of symptoms or reduction of disease progression. Other things, endometrioma may change in appearance during pregnancy, and they can appear like malignant cysts, and this is very important to know. And the clinician should also be aware that there may be an increased risk of first trimester miscarriage and ectopic pregnancy in women with endometriosis. So we should know also in patients with endometriosis, we have a higher risk of pregnancy loss and ectopic pregnancy, even with ART. In endometriosis recurrence, surgery is indicated in women with an endometrioma, but we should do a very special cystectomy to not have a very low reserve after. And if we want to conceive, it's better to do or oocyte preservation or ART before doing the surgery to avoid to have after the surgery a very low AMH. For medical therapy to prevent recurrence, ESHRE guidelines recommend that we can consider to prescribe post-operative levonorgestrel releasing intrauterine system, or a combined hormonal contraceptive, at least for 18 to 24 months. This will decrease the risk of recurrence of endometriosis. And after surgical management of ovarian endometrioma in women not immediately seeking conception, we have to give a long-term hormonal therapy to avoid recurrences. And for the prevention of recurrences of deep endometriosis, long-term administration of post-operative hormone treatment can be considered. And ART, this is very important, ART does not seem to increase endometriosis recurrence. So the stimulation will not push the endometriosis to development. To finish, I will put here some take-home messages about the new ESHRE guidelines. Surgery could be considered for fallopian endometriosis lesion or endometriosas, especially when it's more than 3 or 4 centimeters, before conceiving if there is no other cause of infertility. And we can use endometriosis fertility index. Never treat surgically bilateral endometriomas. The guidelines does not anymore recommend an ultra-long protocol for the woman with ESHRE stage 3 or 4 endometriosis to improve IVF success rates. No indication for surgery in deep endometriosis in infertility. ART is the first-line treatment before surgery in endometriosis-associated infertility if there is a low ovarian reserve or sperm abnormalities associated. Laparoscopy is no longer the gold standard for diagnosis of endometriosis. Laparoscopy is still only the gold standard for confirmation of superficial endometriosis. Imaging, ultrasound, and MRI are good tools for the diagnosis of ovarian or deep endometriosis. For chronic pain in endometriosis, progestogens can be used, combined pills or aromatase, and could be used as long-term treatment. Lifestyle and diet could help in coping the pain in endometriosis. Thank you very much, and hope you will enjoy your webinar.
Thank you, Dr. Abitaya. It's clear that the 2022 guidelines erased a lot from the 2014 endometriosis guidelines with regards to management of endometriosis. The new guidelines, as you said, introduced new things. GnRH antagonists are introduced as second-line treatment. Danazole, antiprogestins, laparoscopic surgical excision, laparoscopic uterosacral nerve ablation are no longer recommended. Pre-op or post-op or even pre-IVF GnRH agonists are no longer recommended. The thing which is important that you mentioned about endometriosis surgical fertility index is added as a step supporting the decision regarding the treatment options to achieve pregnancy. And the most important of all is the post-op GnRH agonist is no longer recommended. Regarding the markers, I'm sure you agree that the problem with markers is their non-specificity. The CD44 can be high in colon and gastric cancer. The PGP, I guess, may be high in some neuroendocrine tumors. As we know about the CA125, it may be high in ovarian cancer. The gold standard of diagnosis remains ultrasound and laparoscopy for sure. I have, I think, one question from Dr. Brahim Al-Ma'moon, who says, do you still give combined oral contraceptive pills post-ovarian endometrioma resection? And do you do AMH level pre-op?
If there is no any plan to conceive, it's better to give a combined contraceptive pills after surgery to decrease the risk of recurrence and to improve the outcome of pain after surgery. So it's good to do it. At IMH, yes, if there's a risk of low ovarian reserve, it's better to do an IMH before the surgery to avoid any decrease in the ovarian reserve. And in this case, if it's very painful and you should do the surgery, it's better to do a fertility preservation before any surgery if the ovarian reserve is very low. So it's better to have an idea about the ovarian reserve before any surgery for endometriosis, if there is any plan to conceive after.
Perfect. So if you don't have any other questions, our next speaker is Dr. Bashar Shbib. He's a reproductive endocrinologist and infertility specialist who will be talking to us about recurrent implantation failures. Dr. Bashar.
Doctor, you can start.
I guess there's a problem from Dr.
Okay,
Bashar.
now it's good.
Okay.
Okay, it's good now.
Yes,
Okay.
we can hear you.
Okay, good evening, everyone. Thanks, Walid, for your introduction. Thanks, George, for your presentation. I will talk tonight about recurrent implantation failure treated by 6 studies in the ESHRE. So as we know, recurrent implantation failure refers to cases in which women have had 3 failed IVF attempts with good quality embryos on apparently responsive and anatomically normal endometrium. The definition should also take in consideration advanced maternal age and embryo stage. Many risk factors. How can I move? Reem. Okay. Risk factors for recurrent implantation failure are advanced maternal age, smoking status of both parents, elevated body mass index, immunologic factors such as cytokine levels and presence of specific autoantibodies, chronic endometritis, uterine pathologies such as polyps, myoma, or congenital abnormalities, sperm alteration, and endometrial receptivity. So it's necessary to determine the etiologies of recurrent implantation failure in order to propose new and beneficial solutions for these patients, and to note that around 5% of women are expected to suffer from 2 consecutive pregnancy losses. Almost 75% are due to implantation failure. So now we're gonna move to the ESHRE highlights. Six studies were discussed in regards of this topic, which is the recurrent implantation failure. And I will discuss each study alone. The first one, does levothyroxine in thyroid peroxidase antibody positive women with recurrent pregnancy loss? It's a multi-center randomized double-blind trial. Patients with 2 or more pregnancy losses underwent diagnostic testing for recurrent pregnancy loss. The primary outcome was live birth. The daily dose of levothyroxine ranged from 0.5 to 1 microgram per kilogram for body weight, and Euthyrox or placebo was continued until the end of pregnancy. Result shows that live birth occurred in 50% in the levothyroxine group and 48% in the placebo group. So, in conclusion, levothyroxine treatment did not result in higher live birth rate in women with recurrent pregnancy loss who are positive for TPO antibodies and normal thyroid function compared to placebo. The second study, it's a randomized controlled trial on recurrent implantation failure treatment in a study model performed on women who failed egg donation cycles using a granulocyte macrophage colony stimulating factor. So 50 women with recurrent implantation failure after egg donation cycles were subdivided in two groups. The first one include 25 women who were treated with subcutaneous GM-CSF in a dose of 0.3 milligram per kilogram for daily basis from the day before embryo transfer to the beta SCG day. The treatment was continued until the 8th week of gestation. The control group of 25 women also was treated with subcutaneous saline solution infusion in the same way of the study group. The primary outcome was for living birth. The main result showed that the ongoing pregnancy rate in the group treated with granulocyte macrophage colony stimulating factor was 48% compared to the control group was 44%. So in summary, the clinical use of granulocyte macrophage colony stimulating factor in women experiencing implantation failure in egg donation may be useful. The third study, it's a randomized controlled trial on the effect of intrauterine HCG flushing on reproductive outcomes. Women undergoing IVF cycles were randomized to no HCG flush group 80 patients and HCG flush group 100. All embryos subjected to blastocyst culture and freeze-all strategy followed. In the HCG flush group, after 48 to 72 hours before embryo transfer, 500 of international unit of commercially available HCG hormone was instilled into the uterine cavity. No HCG flush group did not have any intervention. So, for the results between HCG versus no HCG group, we see that the clinical pregnancy rate is 71% versus 76% in the group of no HCG. The implantation rate, 59% versus 55% is a no HCG group. And this data shows that from this RCT, that HCG flush does not seem to enhance embryo implantation. So in summary, uterine flushing with HCG does not seem to enhance embryo implantation and optimize reproductive outcomes. The fourth study, does a vaginal lactobacilli probiotic treatment improve an unfavorable vaginal microbiome before fertility treatment? Patients completed a 10 days treatment with vaginal probiotic capsules containing 2 souches of lactobacillus, gasseri, and rhamnosus, and the other group, placebo. And in summary, the probiotic treatment did not improve the vaginal microbiome compared with placebo. However, spontaneous improvement of the vaginal microbiome was observed in 34% of all participants. We move to the fifth study that studied the factors affecting biochemical pregnancy. So, the trophoctoderm biopsies on day 5, 6, and 7 blastocysts were analyzed by NGS. The biopsied embryo were vitrified and transferred in subsequent cycle. 2 embryos of good quality were transferred, and the indication for PGTA were advanced maternal age, altered karyotype of sperm fish, history of chromosomal abnormalities in the offspring, repeated miscarriages, and recurrent implantation failure. In summary, there are other factors such as paternal, maternal, ovarian stimulation, endometrial and embryo biopsy factors that are associated with the rate of biochemical pregnancy after the haploid embryo transfer. And they transfer 2 embryos of good quality at day 5. The last study was an RCT of intrauterine administration of a granulocyte colony stimulating factor before embryo transfer in resistant thin endometrium in IVF ICSI cycles. The primary outcome was endometrial thickness, implantation, and pregnancy rate. The study group received intrauterine infusion of 300 microgram per milliliter of GCSF, and the control one underwent placebo saline infusion before embryo transfer. GCSF was administered by intrauterine catheter by slow initiation on the day of HCG administration, and if the endometrium had not reached at least a 7 millimeter within 48 hours, a second dose was administered following oocyte retrieval. The main result showed that endometrial expansion to optimal thickness occurred within approximately 48 to 72 hours of GCSF initiation. The implantation rate and pregnancy rate were statistically significantly higher in the group receiving intrauterine growth, the granulocyte CSF, compared to the control one. Abortion rate were comparable in both groups. So in summary, intrauterine administration of granulocyte colony stimulating factor before embryo transfer in resistant thin endometrium increases endometrial thickness and improves the pregnancy rate in IVF ICSI cycles. Thank you.
Thank you, Dr. Bashar,
Thank you.
for this interesting lecture. Well, I guess in the end, we will discover that recurrent implantation failures is mainly a problem of two things, the embryo and the endometrium. And our treatments should be focused on treating the embryo. And most of the current research is currently on the chromosomal aberrations in embryos that are causing implantation failure. And this is why patients undergoing pre-implantation genetic testing for aneuploidy, we are seeing that high pregnancy rates when we transfer single euploid embryo. The treatment of the endometrium, we still don't know exactly what is useful. IV and immunoglobulin seems to be useless. Steroids too, aspirin, heparin, peripheral mononuclear cells. We don't really know what will help. Before we move to the next topic, we have two questions. One from our friend in Jordan, Dr. Khaldoun Khamaisa. Hello, Dr. Khamaisa. He is asking about the role of CA, and this question is for Dr. George Abitaya. He is asking about the role of CA19-9 in endometriosis, in the diagnosis of endometriosis. It seems he has a patient with very high CA19-9, and all what he can see in her is endometriomas. So he's asking about the risk of concomitant presence of ovarian cancer. This is a question for Dr. George Abitaya. And the second question is from Dr. Ghassan Atalla. I don't know, he's asking how much do you wait after LPS to start ART? If I understood the question right, LPS, do you mean lipopolysaccharides? Because lipopolysaccharides, I believe some try it in the treatment of chronic endometritis. I don't know if it has a role in endometriosis. And again, we would like to ask Dr. George Abitaya to answer Dr. Atalla.
For the first question, Walid, I don't know how he put the diagnosis of endometriosis, but if we have a very high level of CA125, we have to be cautious because the risk of cancer is very high. So I think we have to do more imaging, MRI and other tests, and if needed, to do a laparoscopy with biopsies and to see the peritoneum and to be sure that it's only endometriosis. Normally, we shouldn't have CA125 more than 500 in normal endometriosis. And the lesion in endometriosis could be very similar to lesions in ovarian cancer. So I think in this case, we have to be cautious if CA125 is very high. For the second questions of Dr. Atalla, there is no indication.
Sorry, he's saying CA 19.9, not CA 125.
Oh, 19.9.
Yeah.
In 19.9, there's less risk of tumor cancer, ovarian cancer. I think it, but I think it's better to do a good imaging. And if there is any doubt, we should do a laparoscopy and biopsies to be sure there's no risk of cancer. All these markers are could be a tumor markers. And if we have a high level, it's better to be cautious and to search for a real cancer before putting the diagnosis of endometriosis or any other benign problem. For the second questions, I don't see in ESHRE recommendation any recommendation about LPS for endometriosis. So I don't think there is any consensual treatment for endometriosis with LPS. It's one of many treatments that we are used to use for endometriosis, but there's no recommendation to use them.
Thank you, Dr. Abitaya. Our next speaker is Dr. Hussam Abdulrida. Hussam is a consultant obstetrician gynecologist and IVF specialist at CMC, Clemenceau Medical Center. After graduating from the American University of Beirut, he pursued a fellowship in assisted conception at King's College in London. He came back to Lebanon and started his practice. Dr. Hussam will talk to us today about new evidence on dual stimulation or double stimulation in the follicular and the luteal phase. Dr. Hussam.
Okay, it's unmuted now. I will share my presentation with you. I will start. Okay, is it shared now? Reem?
Yes, you are on and we can hear you and it's shared.
And it's shared the presentation. Thank you, Dr. Walid, for hosting us. It's a good opportunity. And also it was a very good opportunity to attend ESHRE in Milan for the first time in person. We really enjoyed it. Today, I will discuss with you the new evidence on dual stimulation. There was a whole session, the session 22, which was dedicated to discuss the new evidence and effectiveness of dual stimulation or double ovarian stimulation, as it is known in a special cohort of patients with poor ovarian reserve. Basically, I will discuss 5 presentations, 5 articles. Please, I just want you all to know that I'm using the slides of the presenters, of the original presenters. So all the credits will go to them. The principle of dual stimulation or double ovarian stimulation was based on the discovery in 2003 that during follicular development, we don't have just only one wave. As you're all aware, we have more than one wave. 62% of patients will have 2 waves and 38% of patients will have 3 waves of follicular development during the same follicular, same ovulatory cycle. So this led to the development of different sort of controlled ovarian stimulation, not only during the follicular phase as we all used to do, Now we are using it in the luteal phase as a random start or emergency start ovarian stimulation, especially in fertility preservation and cancer patients. And also nowadays we are using dual stimulation or double ovarian stimulation. The principle of double ovarian stimulation is to start the first stimulation in the follicular phase on the second day, then to trigger do the oocyte pick up, then a couple of days, 1 to 5 days, to start a new stimulation, ovarian stimulation with FSH and the luteal phase, then do a trigger, then do a second ovarian pickup. The first protocol was developed by a Chinese group, the Shanghai Protocol, and is still known as Shanghai Protocol in 2014. The same protocol was adopted and developed by the Ubaldi group or the Fiorelli group, which proposed also an adapted protocol for double ovarian stimulation. The original data or results by Shanghai group was a little bit promising because they showed that the luteal phase stimulation was associated with 1.5 increase in the number of oocytes collected compared to the follicular phase. And the Ubaldi group, at least they showed non-inferiority of the luteal phase protocol concerning the number of oocytes collected, the fertilization rate, and more importantly, the number and the rate of euploid embryos. And they suggested a little bit that double stimulation could lead to accumulation of a higher number of euploid embryos in a shorter time duration. So now I will start with the first study, mainly dealing with poor ovarian responder patient. Will double ovarian stimulation result in higher number of oocytes or clinical pregnancy rate? This was a randomized controlled trial, RCT, done in France in 5 centers or 4 centers in France. The main outcome was to compare the number of cumulated number of oocytes retrieved in poor responder. They compared two stimulation protocol, double ovarian stimulation on the same cycle to a control group who had 2 consecutive conventional stimulation cycle with antagonist protocol. The statistical hypothesis was to demonstrate the data or the findings of the Ubaldi and Shanghai group that double stimulation could lead to 1.5 oocytes more induced stimulation, and therefore they needed 28 patients in each group with a 35% anticipated cancellation rate, so they needed 44 patients per group. It was, as I said, multi-center randomized trial in September 2018 to March, and the inclusion criteria were based on the Bologna criteria for poor responder. So the 2 stimulation were the control group and the conventional group started with 300 mg with the antagonist protocol. And the Ubaldi group, for the DU-STEM, they used the GnRH agonist protocol. Here they used the HCG trigger, and the conventional group also the HCG trigger. And what they did oocyte vitrification after the first pickup in the DU-STEM. And the conventional group, they did fresh or frozen embryo transfer. They did the fresh embryo transfer if there was an unexpected good response with a good number of oocytes. They switched the protocol and they did fresh embryo transfer. And the DU-STEM 1 to 5 days later, they started a new stimulation with 300 international units, but this time they used progesterone for suppression against beta HCG trigger and pick up. And then later on, they did a frozen natural cycle. So 44 patients were randomized in each group. 17% ended up having a second stimulation in the conventional group, and 29 patients in the DU-STEM group. The result, there was no significant difference regarding the basal characteristic and demographic characteristics of the 2 groups. And the primary outcome was there was no difference of the number of cumulated number of oocytes between the conventional and the DU-STEM. So no significant difference. There was a little bit of trend towards suggesting that DU stimulation might have a higher number of oocytes, but wasn't statistically significant. But surprisingly, what we were surprised with, that conventional patient underwent conventional protocol had a higher number of embryos, and especially embryos suitable for transfer. It was 1.5 compared to 0.9. And the percentage of embryo transfer, there was 32% in the conventional and 21 in the DO-STEM. Despite that, the number of oocytes was almost the same between the two groups, but the conventional group had a higher number of embryos available to transfer. And of course, the time to transfer with going pregnancy was a little bit shorter in the conventional group because patients with good response were offered to have a fresh embryo transfer immediately. And the cumulative live birth rate was higher, and the conventional was, of course, it wasn't statistically significant. The clinical pregnancy was higher also in the conventional group and not in the DO-STEM group. When they compared the two cycles, especially in the DO-STEM group, to see if the luteal phase was associated with a higher number of oocytes, there wasn't a higher number of oocytes in the luteal phase as compared to the Ubaldi and to the Shanghai group. So in conclusion, the total number of oocytes retrieved in poor responder is similar with DO-STEM compared with 2 consecutive cycles. The accumulated number of usable embryo is reduced in DO-STEM. The time to pregnancy is longer with DO-STEM, but not statistically significant. The main limitation of this study that could be associated with a lower number of embryos, usable embryos, is that they did oocyte vitrification of the first cycle of stimulation and the DO-STEM. And also there was a higher number of unexpected good responder and pregnancy after the first pickup and this relatively young population, and the trigger was performed by beta-ECG and not by GnRH agonist. So in conclusion, in routine practice, the benefit of DO-STEM is not really demonstrated for patients with poor response. The second stimulation, the principle was very nice, because if you go back to basics, why it was suggested that DO stimulation might benefit patients with poor responder, because we strongly we have this belief that FSH stimulation in the follicular phase might help recruiting smaller follicles, and these smaller follicles will become more sensitive to FSH that will give and the luteal phase, therefore will be more able to recruit this sensitized oocytes in the luteal phase, and this what might contribute to the higher number of oocytes in the luteal phase. So this idea of this study came from this. So why not to use FSH, continuous FSH, without stopping the FSH like it was done in the Ubaldi protocol, where they stopped the FSH on the day of trigger, and then they stopped for 5 days and they started again the FSH. So why not to stop it, to continue with the FSH? We give the trigger, we continue the FSH, we do the pickup, and we continue for the FSH for a maximum 13 days of stimulation, and then we do the second pickup. The inclusion criteria was also for poor responders, and the study design, this was a single center study with a single blind proof of concept, superiority design. The primary outcome was the number of metaphase 2 oocytes, the number of oocytes that will be collected, and there was secondary outcome, of course, the fertilization rate, number of embryos, and the superiority was defined as an increase with NM2 in accordance with the Ubaldi study. The sample size was calculated to be around 46 patients. So they randomized 48 patients, 24 in the control, 24 in the study group, and 60.9 patients underwent a second oocyte collection. There, of course, the basic characteristics were the same between the two groups. The surprise was, the result was really a surprise, because patient in the control group, despite patient in the control group had only 1 cycle of stimulation of pickup, and patient in the study group had 2 cycles, one in the follicular phase, non-stop FSH, and one in the luteal phase, the number of oocytes was similar between the two groups, 5.3 in the control group and 5.3 in the study group. And the number of M2 also was similar. And this was a little bit surprised. And when they compared the number of oocytes after the first egg collection in the conventional and DO-STEM group, the number was 5.3 in the conventional and the control group, and 3.3 in the study group. And this was really low compared 5.3 to 3.3. So the expectation were that we'll have a higher number of oocytes, but the number of oocytes was really lower. When they controlled they would look for the reasons, they checked the characteristics of the ovarian stimulation. It was the same. Even the number of follicles, more than 17 millimeter, was the same on the day of trigger. And the E2 was named at the same of trigger. The only difference is that we continued the FSH during after trigger and during oocyte collection. And this might have affected the number of oocytes. And also the second difference was in the study group, they used the GnRH agonist. In the control group, they used the HCG. So in conclusion, the study was a little bit small with a heterogeneous group, and there was suboptimal number of oocytes collected. And this might be due to the use of FSH and the GnRH agonist. Maybe this specific group of poor responder, they do well with the HG trigger. But when they look at the pregnancy rate, again, another surprise, the pregnancy rate and the live birth rate was higher, and the DUPIC and the DUSTEM group, I don't know how. This study was full of surprises, honestly. I will start with the third study. This study was not in poor responder, was a normal responder patient undergoing egg donation. So normal responder patient undergoing egg donation. What they did, they used 225 international unit, agonist trigger, they did the pickup, and then a couple of days later, they started again 225 recombinant FSH. The suppression was done with progesterone and stimulation and the luteal phase. Again, agonist trigger, and they compared the outcome between the two cycles, between the follicular and luteal phase. Again, surprisingly, there was a significant higher number of oocytes in the follicular phase. In the follicular phase, they had 16.4 oocytes in the first cycle in the follicular phase compared to 11.4 in the luteal phase. This was also a surprise because we're expecting to have a higher number of oocytes in the luteal phase in accordance with the group of Baldi and Shanghai group. So a normal responder and patient undergoing egg donation, the number of follicles was higher in the follicular phase. In conclusion, this data is the findings are a little bit encouraging. Double stimulation will help with the possibility of achieving more oocyte in less time if you want to do 2 cycles in 1 month. So, but the number of oocyte was lower in the luteal phase. The first stimulation, it was from Egypt, from Alexandria, where they compared, this was a randomized controlled trial where they used progesterone, the hydroprogesterone, for prime double stimulation. Then they compared the outcome. So the aim of this work was to compare the fertilization rate, the implantation rate, and clinical pregnancy rate between the progestin prime double stimulation protocol and 2 cycles of conventional GnRH. So it was almost the same principle of the first study. In this study, the only difference was they were using progestin to suppress in continuous way. So the primary outcome was to compare the number of oocytes. The secondary outcome was to compare the fertilization rate and resulting embryo number. This was a controlled trial which was registered. Patients enrolled were 90 infertile patients indicated for ICSI. Patients were divided in 2 groups, 45 in the study, 45 in the control group. The stimulation protocol, they started the hydroprogesterone on the second day. Then this day after, they start with the gonadotropin on the second day of menses. The first stimulation, the trigger was done by GnRH agonist. Then they did the pick up. Then a few days later, they started the gonadotropin. The day after the pick up, again GnRH agonist with a non-continuous dihydroprogesterone from the follicular phase to the luteal phase. In the conventional protocol, they started the hydroprogesterone. They did gonadotropin stimulation, GnRH antagonist, not progesterone, sorry, GnRH antagonist. They triggered with agonist. And in the second stimulus, the conventional cycle, they triggered with STG because they were considering to do fresh embryo transfer. So 90 patients were randomized, 45 in the control and 45 in the second group. 41 patients were analyzed in the control group and 42 patients in the study group. So when they compared the outcome between the dual and the antagonist protocol, so it was a comparison between dual prime progesterone study and the conventional antagonist protocol, there was a significant number of follicles and oocytes in the dual protocol in accordance with Ubaldi. So this is the only study that showed a high number of oocytes and follicles and in the dual stem protocol. So the number of oocytes and follicles and M2 was higher in the dual stem. For the pregnancy, clinical pregnancy and ongoing pregnancy, there was no difference. Only the difference was in the number of follicles. When they compared the follicular and luteal phase stimulation, also in accordance with the Ubaldi group, they found a significant higher number of oocyte and M2 embryos in the luteal phase that resulted in a luteal phase compared to the follicular phase in this population of poor responders. I have one more study to present to you. So the conclusion of, so there was no difference between progesterone prime dual progesterone and the antagonist protocol, and the antagonist protocol could be associated with a lower number of oocytes. The dual stem did better than the conventional, and there was more oocyte and the first stimulation and the follicular phase. The last study, it was done in a specific group of patient with poor responder coming for PGTM. So they were questioning whether dual stem is a good option for PGTM patients. As you are aware, for PGTM patients, you need a higher number of embryos compared to PGTA because the chances of finding a normal embryo not affected by the genetic disease out that we are looking at the normal embryo is a little bit low and will increase with every oocyte and embryo available. That's why the main aim in PGTM is to have more embryos to examine. So poor responders when included in a multi-center case series study. So 90 patients were enrolled in this study. Okay, 29 patients refused to use stem and 61 patients accepted to undergo a second stimulation during the same cycle. Gonadotropin, GnRH agonist, pick up to stop according to Ubaldi group. Then starting a new gonadotropin cycle, GnRH agonist for suppression, and then agonist for trigger. So 61 patients underwent double stimulation. The primary outcome was the chance of obtaining more than one euploid or unaffected blast. This was the main outcome. The secondary outcome was the clinical pregnancy rate. The results were a little bit complicated, but you can see that 38 of patients had more than one transferable embryo in the first stimulation, 39 in the second stimulation, with a total of 59 if we combine the first and second stimulation. So 59% of patients had more than normal embryo suitable for transfer, and that could respond to 21% increase. The clinical pregnancy rate was 37% in the DU-STEM and 21% in the conventional. And additionally, the live birth rate was 37% in the DU-STEM and 21% in the conventional. And there was more patient in the DU-STEM, more patient who had more than embryo to transfer. They had 1.7 surplus embryo to transfer. The conventional group didn't have any additional embryo to have a second embryo transfer. So the limitation, this is a small study, ongoing study. It's more like a pilot study. It helped to do a comparison between DU-STEM versus 2 consecutive convention in a setting of PGTM. And this was a cost-effective analysis in different settings are desired to compare DU-STEM and the conventional in patient undergoing PGTM. The main conclusion and future perspective, DU-STEM is a fully personalized strategy that could be promising and poor responder. based on the expected risk that each embryo would be affected, or an haploid 5 blastocysts represent a reasonable cutoff to suggest duostem in progress. So if you have an impression of if you did a first cycle and there was less than 5 blastocysts, according to this study, is suggested to start a new wave and to start a new stimulation immediately. So this was my presentation. In conclusion, duostem could be a good option for fertility preservation for patients undergoing fertility preservation. Therefore, will be able to collect more oocyte before chemotherapy, and could be a good option for having more haploid embryo for PGTA in a shorter time interval. But the effectiveness of the stimulation in poor responder, the results were a little bit conflicting, and there wasn't any robust data to recommend the stimulation in poor responder yet. We're still waiting for bigger study and larger randomized study. Thank you. Thank you all for attending.
Thank you, Dr. Hussam, for this, I would say, an excellent presentation.
Thank you.
It may be that one of the under-credited breakthroughs in assisted conception is the discovery that folliculogenesis in women occurs in multiple waves and not in one wave. And it can be up to 2 to 3 waves in a cycle. Thus being able to obtain more eggs in a shorter period of time in a very safe way, which will allow us to preserve fertility, especially in oncology patients. I agree with you that one of the deficiencies in data, however, is the absence or scarcity of good cost-effective analyses of these procedures in pre-implantation genetic testing for monogenic or aneuploidy cycles. I have to admit, consider it a question or a comment that in the study that they attempted to use continuous FSH, I don't know how we may not be wasting 4 or 5 days of FSH waiting for luteolysis. I didn't understand really how and why we continue giving FSH. I don't know if
the basic principle, Walid, for the stimulation is giving FSH in the follicular phase will help us sensitize and recruit the smaller follicles. So when you do the first pickup, the smaller follicles that still available in the ovaries, in theory, they should be more sensitized to this FSH, and we should be able to recruit them faster. That's why they continued the
but
FSH.
how can we, are we sure we can stimulate them and they're responsive before the 5 days window of luteolysis? I don't know.
I think this was the negative side of the study. At least it's proved a point that there is no point of continuing FSH after pickup and not allowing enough time for luteolysis before starting a new cycle. And I think it was a beneficial study. It proved a point, honestly.
Yeah. There's one question from Dr. Ibrahim Al-Ma'moon. He says, should we recommend PGTA to all embryos in duo stimulation, as most patients have low ovarian reserve and are above the age of 35? I don't know if this is true.
Recommending PGTA, it's based on your practice, whether you are, and PGTA is a little bit, there was a bit confusion around it. Some people might agree with offering PGTA and people might not agree. But the principle of doing duostem for having more haploid embryo and shorter time duration, at the end of time, Walid, we are saving 15 days in doing duostimulation. So if you do a first stimulation and then you wait for 15 days and you start the second stimulation, we don't think that 15 days it's really very important in patient having PGTA cycle if they are not having chemotherapy or oncology. At least this is my point of view. So 15 days will not make a big difference. But here, some might raise the possibility that doing back-to-back cycle the patient will not get tired easily if you let her wait for 2-3 months to do her stimulation. So it might have some psychological just benefit in doing these cycles in shorter time of duration.
For regular IVF patients, I think, answering Dr. Ma'moon, if we live in the Republic of Plato and everybody is covered for IVF, I think every patient should have PGTA.
Yeah.
Now, our last but surely not least speaker is Dr. Joseph Azouri. Dr. Azouri is one of the few who started IVF in Lebanon back in the 80s. He is the chairman of OBGYN at Mount Lebanon Hospital, which is affiliated to Balamand University Medical School. He is the founder and medical director of the A. Azouri Clinic. Dr. Azouri's lecture shall be presented by Dr. Jessica Azouri, PhD in reproductive biology and director of Azouri IVF Clinic. Jessica, you're online.
Hello, everyone.
Hi.
I'm sorry.
We can hear you, Jessica.
Okay. So I'm sorry, Dr. Azouri could not be present. Actually, he's still in the hospital for an emergency case. That's why I will be presenting on his behalf. And he is sorry about this inconvenience, actually. So back in 2022, Dr. Azouri participated in the same webinar about the best of ESHRE 2020, and he had a talk on time-lapse updates. His the three final slides were, in addition to automated annotations and algorithm development, there's a massive explosion of interest in developing artificial intelligence on time-lapse. At that time, many papers were starting to be published about embryos that are selected or that are graded by artificial intelligence. And his last slide was, in the very near future, embryo selection will not be the one we know right now. Indeed, this huge interest in artificial intelligence and embryology has been shown this year in the ESHRE 2022 as 5 sessions or 4 very important sessions were dedicated to the subjects, each one consisting in 5 talks, and all of them were done in the Gold Room, which was the biggest auditorium and the one that has the biggest capacity. So session 2 and session 41 were about automation tools for embryo evaluation. Session 34 consisted in a debate about artificial intelligence in the IVF lab. And session 59 was exploring new possibilities for evaluating embryo ploidy. I will surely not go through all the talks, but we selected a few of them about artificial intelligence in embryology. So this study from the group of Nelly Friedman in France wanted to check, just one second. Wanted to check whether deep learning for embryo quality assessment reduces inter-observer variability. And this study has shown that artificial intelligence is showing precious value to the field of embryology, from enhancing blastocyst quality prediction to removing inter-observer subjectivity. This study from a Japanese group wanted to check whether embryo score calculated by annotation-free embryo scoring system based on deep learning and time-lapse sequence images correlate with live births and neonatal outcomes. So as we know, in general, when we are using the time-lapse, the embryologists have to annotate the embryos. So they have to press when it's 2 cells, press when it's a blastocyst. So this is called annotation. And this group, they wanted to check an artificial intelligence annotation-free embryo scoring system. In this study, a total of 3,010 single vitrified worm blastocyst transfer cycles were analyzed retrospectively. And they conclude that objective embryo assessment using a completely automatic and annotation-free model, the IDA score, correlates with decreased miscarriage and increased live births and has no correlation with neonatal outcomes. In this study, that was a collaboration between a Turkish and an Israeli group, they checked whether Chloe, which is an artificial intelligence algorithm, will predict efficiently blastulation, pregnancy, and ongoing clinical pregnancy following single embryo transfer. And indeed, they showed that Chloe algorithms are effective predictors of blastulation, ploidy, pregnancy, implantation, and ongoing clinical pregnancy. This study is a little bit different from the others because all the other studies, they just analyze time-lapse images or videos of embryo. But this study added something new. So they added some clinical data to the time-lapse images and videos. So clinical data like the body mass index and like the age of the patients. And they wanted to check if this will enhance the prediction of the artificial intelligence. So the question was, can artificial intelligent algorithms assist embryologists in evaluating embryos from any time-lapse system along with clinical data to better predict pregnancy outcomes and reduce time to pregnancy? So a total of 2,519 patients were included in 11 different European fertility centers using 4 different time-lapse systems. And this algorithm, Embryoli, significantly increases accuracy in predicting clinical pregnancy by 27% when clinical data is included. So when we do the machine learning for the artificial intelligence systems, when we include clinical data, their prediction capacity becomes higher. So this study is a huge study also from Campbell, who is one of the biggest names in the United Kingdom and who started working with the time-lapse, the first one who started working with the time-lapse. And she wanted to check whether this artificial intelligence can annotate embryo like manual annotation. So as I told you before, in general, when we are looking at time-lapse videos, the embryologist should annotate the embryos, and this takes a lot of time. This is essential for creating the data, but it takes a lot of time from the embryologist as it requires 5 minutes per embryo. And with a big number of embryos, this is very time consuming. So Campbell worked on a machine learning model and she wanted to check whether it will produce annotation compared to manual annotations. This was also a multi-center quality assured annotation data from 63,000 time-lapse monitored embryo, comprising more than 400 million individual images that were used to train the machine learning model to automatically generate morphokinetic annotations. And is that the model they created automatically annotated unseen embryos with comparable results to manual methods. So they were able to develop an algorithm that is able to annotate completely automatically the embryos. So now, after we've seen annotating and we've seen that this artificial intelligence, they can predict the outcome of the embryos. Now we will see 2 talks where artificial intelligence is used to predict ploidy of the embryos. So this study from 6 different eugene groups in Brazil wanted to check whether it's possible to estimate blastocyst ploidy with an artificial intelligence algorithm built using embryo morphokinetics data. And the answer is that the use of artificial intelligence for embryo assessment is a promising tool in IVF labs. In their model, using only morphokinetics, a considerable predictive power to evaluate euploid and aneuploid embryos was achieved, indicating a potential use of a non-invasive approach for embryo ranking and selection. Similar results were obtained in Valencia and the group of Carlos Meseguer, who is one of the biggest names in the field of time-lapse and artificial intelligence. And he also worked on developing an algorithm that predicts ploidy. And the spatiotemporal model they developed can distinguish aneuploid embryos from euploid embryos using time-lapse videos with an accuracy of 72%. So with further studies with a larger number of time-lapse videos, they can reach a potential translation to clinical use, and artificial intelligence might be a substitute to genetic testing. So this last study it's not the last one actually, the one before the last one. So it was a systematic review and meta-analysis, and it included 18 published studies. And it concluded that the majority of the artificial intelligence-based models could provide an accurate prediction regarding live birth, clinical pregnancy with fetal heartbeat, and embryo ploidy status. Artificial intelligence is a highly promising tool providing precise predictions. However, it does not appear to considerably surpass human prediction capabilities. So it's surpassing, but not considerably until now. And more studies and more collaborations between developers are needed prior to artificial intelligence becoming the gold standard. So as we have seen in this talk, like each group or each small group of labs are developing their algorithms alone, and this reduces the development of this intelligence. If there was more collaboration between the different groups, higher numbers of embryos will be used to teach this artificial intelligence, and I would think that we will get to a development that is quicker. Even though the developing that is happening right now is very quick, since all this happened in the last 3 years. Now, this is the last study, and it's from an American lab. So this one is the only one that contradicts all the others. Okay, so they wanted to check what the level of agreement between different artificial intelligence algorithms and embryologists when ranking blastocysts. So 5 international embryologists ranked embryos using single images. 3 also ranked embryos using time-lapse machine videos. 8 international artificial intelligence companies anonymously ranked the embryos using artificial intelligence models. Half used single images, while the other half used full videos. So the summary answer of this study is that, in general, embryologists have a stronger level of agreement with each other, whereas artificial intelligence algorithms differ greatly between embryologists and among each other. And this is in controversy, especially with the study of Nellie Friedman, the first one I showed you, that has shown that there is a big inter-observer and intra-observer variability between embryos, and that artificial intelligence has less variability, while this study shows the contrary. So in order to finish, artificial intelligence embryo grading is not here to replace embryologists, but it gives embryologists a lot of benefits because it can save them a very precious time. They can spend less time grading and noting on paper, less time on data entry with more data, a lot more data, less time on data error checking, and less time on trying to standardize from an embryologist to another. So the take-home messages are that AI, in fact, can provide accurate predictions. Although AI models appear effective, they still have some way before they can claim to significantly surpass clinical embryologists' predictive competence. AI should be employed as a useful tool to make recommendations for the embryologists, not to replace them. And embryologists should become familiarized with artificial intelligence, and the next generations should be trained accordingly. Artificial intelligence is not always that intelligent. We have to keep this in mind, and this photo actually appeared in one of the presentation during the debate about artificial intelligence, but it really was interesting. So that's why I decided to re-put it in this presentation. So this image shows obviously a cat, but this cat has strips on its body because of the shadow that's coming from the bars. And artificial intelligence will not analyze this way. It will interpret this cat as a tiger. So artificial intelligence is just as a machine. It has only binary information, and we are making it learn by showing it pictures, but it will never have analytical properties, and it will never have the intelligence of a human being or the intelligence of an embryologist. So it will never replace embryologists. Thank you for your attention.
Thank you, Jessica. Like the cat, I don't know how Chloe will be able to be good enough to select a euploid embryo if it's not there. So I don't know, but many believe that a euploid embryo remains the most important factor behind a successful pregnancy. Maybe artificial intelligence will be able to facilitate an embryologist's job by grading the embryo in a faster way, but never to be able to select the best embryo according to all the parameters, including chromosomal aberrations and so on. Before we conclude, we have two questions. One from Azuri Clinic. A patient with recurrent implantation failures, even with oocyte donation. The question is for Dr. Bashar. Which treatment pattern do you suggest for such a patient who underwent several IVF cycles and several egg donation cycles and still didn't succeed? And we still have another question for Dr. Hussam Abdurrida from Dr. Lamia Sayer, who's asking, is a dual stimulation protocol trigger with ACG, as you mentioned in one of the studies, before the first pickup, will it affect the second wave by causing prolonged luteinization or not? And isn't the GnRH antagonist trigger not the standard? I guess, Dr. Bashar, if you can answer the first question.
So my question clearly for Dr. Bashar was, between what you presented for us, which one convinced you the most personally? I think he's muted. I think Dr. Bashar is muted.
Okay, sorry. So for this kind of patient, I have first of all to rule out if she has uterine pathology or chronic endometritis by doing hysteroscopy. I have to rule out male factors. I have to study the endometrial receptivity doing, for example, ERA test. And then if all these factors are ruled out, so she can benefit, like I said, from these 6 studies, doing or GM-CSF or GCSF initiation of intrauterine initiation and PGTA. And why not she can profit also in the future from the artificial intelligence you talk about. I think this
no, so the
two
GSM after ERA and all these things, so you were convinced mostly by the GSM.
GM-CSF is better. If she has a thin endometrium, I will go for Nopogen. I have a good experience is Nopogen for thin endometrium, and it shows a good result for this kind of patient.
Okay, thank you.
You're welcome.
Dr. Hussam, regarding the question.
I agree with Lamia, because the group that published the study with the beta HCG trigger, there were a lot criticized during the presentation because the standard was the UTNH agonist, and the reply was that they used the beta HCG for just to to make the two groups comparable as much as they can between the conventional. Because in the conventional group, they use the beta ECG in order to do a fresh embryo transfer if they get surprised by unexpected good response. So they wanted to standardize their treatment between the study and the control group. That's why they used the beta ECG. So it was just for randomization purposes. But I agree with her because the standard is the use of GnRH agonist. And this was the principle of DUSTEM.
Any other questions? Okay, I guess it was.
Can I ask another question for George, if he's still with us?
Yes, Bashar, I'm here.
George,
Yes.
okay. بطل في كهرباء.
No problem.
So one more question. For example, if I have a patient with endometriosis with recurrent implantation failure, okay, and if we go for ART and with recurrent implantation failure, does the operation of endometrioma can give better result for this or no? يعني بتخفف التوكسيسيتي for the endometrium من وراء الانdometrioma. We can do after, for example, doing the freezing of embryo and oocyte retrieval and everything, and then I go to operate to ameliorate the implantation rate.
In the recommendation, the ESHRE recommendation, they don't talk about surgery just to improve the implantation rate when we have the embryos. What we know is now that if we do a freeze-all for endometriosis with use of antibiotics and to transfer in the second cycle, we have an improvement of implantation in case of endometriosis. Now it's recommended to do a freeze-all and to transfer in the second months. But if we have to do the surgery before the transfer, there's no recommendation, and I don't see papers about this. What I think, if we have a very good ovarian reserve, we can opt for a surgery for pain and to improve the climate of the endometrium. We know that if there is endometriosis, the quality of the endometrium is not the same. But I don't have real data or LCTs about this to tell you that it's good to improve the implantation failure if we remove an endometrioma or we do a surgery for a deep endometriosis.
Okay,
The only things proved that we have to use antibiotics, and it's better to do a freeze-all in endometriosis.
Okay. Thank you, George.
Thank you, everyone, for presenting and attending. I hope you will all join us soon on our September 8th webinar. And I hope it will be as interesting as this one.
Thank you, Walid.
Thank you.